All right, everyone. Let's go ahead and call roll. Arion,
Ariane Permar.
Cameron, Pierce, Cameron Lanford,
Cameron Lanford.
Charlotte McMahon,
Charlotte McMahon.
Krista Joby, Sierra Mitchell,
Sierra's here.
Claire Kimichek,
Claire Kamichik.
Cynthia Earhart, Dylan Bell,
Cynthia's
Dylan
here.
Bell.
Emily Burke, Faith Pinkney, Jen Hernandez,
Faith Pinckney.
Bang,
Second Sims here.
You got a white 19 F-250.
Jen Hernandez, is that you?
Yes, it is.
Kelsey Herring, Leslie Williamson, Maddie Dole, Maria Baruffi, Mazora Rocha, Mitchell Hinton,
Mitchell N.
Nicole Tenorella, Noah Wilson,
Noah Wilson.
Ryan Jackson,
Ryan Jackson.
Sarah Coker,
Sarah Coker.
Sierra Altman,
Sierra Altman.
Stephanie Wilcox, Tony Warnick, Vishnu Kudavada,
Tony Warnick.
Wilson,
Kudivada.
Wilson Maddox.
Wilson Maddox.
Okay. If you don't see your name, I don't have you. Cameron Pierce, you're not here. Krista Joby's not here. Emily Burke's not here. Kelsey Herring, Leslie Williams.
Kelsey Herring is here and Stephanie Wilcox is here. They typed in.
Thank you. Emily Burke, you're not here. Leslie Williamson, not here. Maddie Dole's not here. Maria Baruffi, Maza Rocha, Nicole Tenorello, you're not here. All right, Emily Burke. Emily Burke is here. Okay, I think that's everybody. Okay, guys, this week in lab, Wednesday and Thursday, you have assessment module. Just reminding you that we will take another module exam this week on assessment, which is literally memorizing the assessment sheet, medical assessment, and doing things in order. So, example, you can't do primary assessment things until you have done a scene size up. You can't do secondary assessment things until you have completed the primary. And you've got to have memorized where those things begin and end. I did a lecture on that, and so the scene size up begins at S in SNACM, and it ends at the MOI-NOI. The beginning of primary assessment is general impression, and it ends at when you say that you're transporting the patient emergently. The secondary begins typically with a sample, an OPQRST or vital signs, and it ends with you reassessing the patient every 5 minutes and calling report to the receiving ALS backup or the receiving hospital. If any of what I just said is foreign to you, then you've got your work cut out for you. So assessment chapter is chapter 10, and that is the chapter you will be tested on for assessment module. I want to remind you that 2 videos are available to you for assessment module review. The medical assessment video and the trauma assessment video, where I demonstrate both. Some things that you're going to see on the exam include the acronyms SNACM, the acronyms RRQ, Rate, Rhythm, and Quality, the acronyms SAMPLE and OPQRST, and DCAP-BTLS. You're going to be asked questions about how to treat for shock, high flow oxygen, blankets, and appropriate position based on the patient condition. So if any of that's foreign to you, then you are going to not be super successful at the assessment module. You might see questions that merely ask you that you've completed these things, what would you do next? And the answer to what you would do next is however it appears chronologically on the sheet. You're also going to see test questions that simply say you have just taken a blood pressure, a glucose, an SpO2. Which part of your assessment are you in? And the answer would be you're in the secondary assessment because you don't take those things in the primary. Any questions? Okay. This week, as you can see from Moodle, we are in week number 8. Started today and it will end on the 16th. And if you look at this week, you will see that it comprises your new material, chapter 12, which is pharmacology, and chapter 15, which is the medical overview chapter. And it also shows you that we're taking the module 3 exam, which is assessment module, which covers chapter 10 exclusively. You cannot do module exam until you have completed the quiz associated with chapter 10. I will change these because this is wrong. 9 would be fine, and 14 would be fine, but 24 would not be fine. That's not an appropriate restriction, and chapter 12 would not be fine because that is associated with the medical module and not the assessment module. I want to remind some of you that you must be successful at assessment module. Some of you are in jeopardy. I don't want that to make you fearful as much as I want it to empower you to lean into studying and making sure that you're really prepared for this module exam. It is not a tough module if you have memorized the sheet. It's not a tough module if you understand the rules of following along chronologically. It's not a tough module if you watched my video on a head-to-toe medical assessment and a head-to-toe trauma assessment. In the medical assessment patient, we are conducting an assessment in the secondary exam that is about the organ systems from head to toe, neuro, HEENT, which if you don't know, you need to know, is head, ears, eyes, nose, and throat. Then you move down into the neck looking for JVD, which is jugular vein distension, looking at the trachea to make sure it is midline and not deviated. You move down into the lungs and you listen to the lung sounds bilaterally. Are they clear? Are they equal? And do I have equal bilateral chest rise visually? You want to inspect the chest and make sure that the chest rises equally. You want to make sure that there is no obvious secondary muscle breathing, which you should know what that means. It means that the intercostal muscles are showing too much work, and so that would infer that the patient is much distressed. Then you would listen to heart tones. Are they clear and distinct? Yes or no? Do they sound far away or underwater? Because both of those would be bad. Then we move into the abdomen and we assess all 4 quadrants by palpating. We're palpating all 4 quadrants looking for pain, discoloration, bruising, tenderness, rigidity, rebound tenderness. If any of those things are brand new to you, you've got your work cut out for you. On the assessment side of the trauma patient in the secondary, we're expecting you to work through a physical palpation from head to toe, looking more externally at the patient for decap BTLS, deformities, contusions and crepitus, abrasions, punctures and penetrations, burns, tenderness, laceration, swelling. If any of that's foreign to you, you're going to need to get into the material. You have not been preparing. Okay, so these last 2 weeks we went a little fast, and so you've had some self-study time. I hope you've made good use of that, as I have warned on GroupMe. We also, if you are successful with the assessment module, We'll be getting on our ambulance rides beginning this week. We will put out the waivers. You will sign the waivers. We will open the schedule so that you can submit your availability. And we will review again the ride-along information that we reviewed last week in lab with both days, because we are going to begin conducting our clinical internships, where we will obtain 15 patient contacts by completing the appropriate paperwork and submitting that paperwork in a timely fashion within 24 hours of the ride-along into the Dropbox made available on Moodle. Those drop boxes are not currently available because we are not riding. But when we do ride, it will be Dropbox 1 for ride 1, 2, 3, 4, and 5, so on, whatever you need. Okie dokie. Any questions? Maddie Doyle is here. No questions at all. Let me see your hands if you can hear me. Make sure all that talking wasn't for nothing.
Justin, have you made weeks 7 and 8 available? Because since like yesterday, it doesn't show up on my end. I'm still on week 6.
I have made week 7 and 8 available, yes. If you don't see it, it might be because you didn't complete the attestation. I don't know if that's true for you. I'd have to go and look. You want to have completed. See, it says that this week is restricted unless Module 2 assignment and attendance attestation has been marked complete. So that might be why you can't.
Yeah, mine's complete. It just says receive a grade, but it's marked as done. But we can worry about it later.
Okay, we'll talk about it and we'll take a look at it and see whatever it is that we need to do to open that up for you. But you got to stay on me about it because I won't remember. So let's make sure we do that. Week 7 completed. So are you saying you can't see week 7?
Yeah, I can't see week 7. My last thing is week 6.
But you did week 7, correct?
Yeah. Mine just goes, that's as far as mine goes down.
We'll have to take a look at that. So you did do quiz chapter 10, and you did the chapter 10 case study, correct?
Yeah.
I can't go look right now because
we can.
I'd be
Yeah,
sharing.
that's fine. We can work out later.
Yeah. So just touch base with me. If I look now, then all of your grades would be displayed, and I can't do that.
I got you.
Week 8 is the same. You can't see week 8 if you didn't do the attestation. It says unless you did module 2 assignment and the attestation, then you can't see it. If anyone's having viewing issues, please let me know because there's a reason and I need to go in and change the restrictions, or you need to complete what it's asking you for. Okie dokie. So this week, I will have week 8 available. I'm going to go open week 9 for you because we're going to enter the medical module, and I've decided that it's easier for me to open up the weeks so that you can visualize them. So you'll see that we're doing about 3 chapters a week going forward. About 3 chapters a week. I'm going to open this up, let you see it. And I'll go play with these dates so that the dates are correct. So basically, I'm going to open up everything up to chapters 24 for the medical module assessment. I'm going to open all of that up. Kind of look at that now so that I don't forget. Right after I get up this ice cube that I just you worry. I'm okay. It's fine. Everything's fine. Just a burning dumpster. Don't worry. Okay. That should be
Copy one.
week 10. I'm going to open up. Is that Jen whose mic is on?
In 601 BLS 3.
Mm-hmm. All the way to 24. And as you can see, we will take Module 4, which is Medical Module, the next week. So you'll take Medical Module on the week of 11/7. So all of Medical Module should now be open. If that's not the case, let me know. For those of you that applies to. Because we can figure out why. So I did notice last week when we took the module exam, I went in and looked, and some of you had not completed the attestation assignment. So if you have not completed them, which is odd because it's sitting right here, and it asks you to complete it by simply clicking on it and saying that it is done, then you can't see the next week. So if you haven't done that, then go and do that. Any questions? Mazo Rocha's here. I don't have a functioning mic at the moment. No problem. Let me go put you on the sheet. Mazrad, you did miss some things, so make sure you go back and look at those things. Okay, let's get into Chapter 12, Pharmacology. You're going to need Chapter 12 for all of the medical module because anywhere that you can give a medication and it's not contraindicated, you will. And so if you go to study guides, one of the first study guides is the medications study guide. And so that is where we're going to build for the lecture before we do the chapter. Okie dokie. Is everyone ready to go? Yes? We can begin? Okay, good. Let's go. So, you will begin by looking at the medications based on the drug name. The drug name comes in two names. The brand name of something and the generic name of something. You need to be taking notes. The brand name of a medication is always capitalized. Brand name just means that the company who put the medication out for that purpose, for that indication, still has a patent on that time frame, which is typically 6 to 10 years. And so if you think of the medication Tylenol, Tylenol will always be capitalized because Tylenol is a brand. The active ingredient in Tylenol is acetaminophen. acetaminophen is the generic. So the active ingredient, acetaminophen, is the generic, which makes it a lowercase medication. If I saw it as Tylenol, it would be capitalized. If I see it as acetaminophen, it will be lowercase. Do you really need to remember all of their generic and brand names? No. I will tell you the ones that the brand versus generic naming is important, and that's based on how we commonly see it. There are some drugs that will come in both versions, and if you didn't know both names, you wouldn't realize that one equals the other. Like, for example, Narcan often comes as naloxone. If you didn't realize that those are the same, you'd be digging in the bag for a drug you have right in front of your face. So I'm going to go over to chapter 12, and you should too, because we want to look at these medications with a little bit of extra from the chapter. First, I want to point your eyes to page 508 and 509. Medications will have multiple dosages based on the fact that medications come in ranges. So I'm going to test you and quiz you in class on this particular study guide. Whatever increments or dosages you see on this study guide is what I'm going to use to quiz you in class. But 508 and 509 are going to give you a little bit more of a range of a possibility to the drugs. What I wanted to do is give you the most common dose, the most readily available use of the drug. So you should study both, but know the dosages based on how I give them to you in this study guide. You're going to see that the book gives some weird dosages for things. Like, if you go over to nitroglycerin, it says 0.3 to 0.4 milligrams. You will never, ever, ever find nitroglycerin in an EMS environment in 0.3 milligrams in this area. So I don't give you that option because it doesn't exist. So that's why you see the discrepancy. It's not that one is untrue or unfactual, it is that it isn't practical. It is not being used in that way, and I want you to be most knowledgeable about what you will actually be seeing on the ambulance and what you'll actually be giving to the patients. So, another thing you're going to notice about the study guide versus chapter 12's page 508 and 509 is that I didn't really include some of the over-the-counter medications like Tylenol, Benadryl, ibuprofen. But that isn't to say that they aren't really important. It is to say that you're not going to be tested on those medications. You may very well go work somewhere like Central Berkeley Fire and EMS that gives the EMT provider the permission to give liquid and pill versions of Tylenol and Motrin and Benadryl. But you may go work a lot of places that don't do that. Here's the deal. The National Registry exam will probably come from the perspective of page 508 and 509. The most practical knowledge will come from the study guide. And some of you are probably like, that sucks that we have to kind of learn both. Yeah, it does. It does suck. But that's the nature of a national realm of scope versus a state realm of scope. And you do have to learn both. Just like the National Registry will not be asking you intricate questions about supraglottic airways because that's not an EMT scope for the National Registry. But it very much so is for the state of South Carolina. The National Registry will not be using the idea of you drawing up epinephrine on your own. They think that EMTs should only be using epinephrine auto-injector pens. We do not agree with that in the state of South Carolina. In the state of South Carolina, an EMT can draw up their own epinephrine from a vial with a needle and give that injection intramuscularly themselves. So then that's what I will teach you. But you must understand that your book is coming from the national perspective. The sheet that you have in front of your face on the screen right now is coming from the practical knowledge that will apply to you as per the state of South Carolina. So, do study both. Do get to know both, because both are relevant, but you have to discipline that relevance from the study guide that I've given you here. Okie dokie. So, yes, every drug on the sheet here, 508 and 509, is important. Yes, every one of the drugs on my study guide are the ones you will be quizzed on in this class. They are the most important medications. No one is going to die in the pre-hospital environment if you don't give them Tylenol for their headache. But people very much so could die in the EMT's 911 environment if you do not give them epinephrine. So that is the practicality that you see between the differences of the book and my sheet. So we will look at these medications from the perspective of the drug name, either brand or generic, brand being capitalized, generic being lowercase. We will look at their indications, which I remind you is the reason to do something. It is the reason we should provide some type of intervention. The contraindication are reasons that we should not, even if it were indicated. You need to take down these two words: absolute contraindication and relative contraindication. Absolute versus relative. Here's the deal. Contraindications in the emergency environment tend to be relative, meaning the risk of giving a medication would typically not be as big as the benefit of receiving it. If you're in the nursing environment, in the non-emergent world, there are things you don't use the medications in your list for. They won't really apply to us because those contraindications are relative. So you might say to me, Justin, when I look at epinephrine, it says that epinephrine causes really high heart rates, and I should be careful giving it to someone with chest pain and a high heart rate. That could be considered a contraindication. And I would say to you, yes, it is. However, it's not an absolute contraindication. It is a relative contraindication. Relative meaning which one is more important. Are they going to die from anaphylaxis if you don't give the epi? Or are they more likely to die from a high heart rate? And the answer is that anaphylaxis for sure will kill people, and having a high heart rate typically does not kill people, even when that rate is very, very high. Absolute is pretty rare in the emergency pre-hospital environment, the EMS world. Relative is almost always our set of contraindications. The patients who need medications from us need them from a level of emergency that would allow us to bypass some of the otherwise stated contraindications. So, in our case, there aren't a ton of contraindications that are absolute. There are some, and we're going to talk about them. But when you're reading page 508 and 509, and you see a contraindication and you say to yourself, why didn't Justin say this was a contraindication? And the answer is because it's so relative in our favor that it wouldn't have mattered. If the patient is more likely to die from the emergency than they are from you giving a drug that they probably shouldn't otherwise have gotten, then you'd give the drug. I wouldn't want to give epinephrine to a patient having a heart attack, but if they were dying from anaphylaxis, I have to. Does everyone understand the difference between absolute contraindication versus relative? Okie dokie. Beautiful. All right. So then we look at dosage. Dosage will simply be your memorization. Did you or didn't you memorize the dose? Route will also be simple memory. Did you memorize the route? So quickly looking from the perspective of the drug name, indication, contraindication, and dosage, route. That is how these are positioned on the study guide. So oxygen is indicated for hypoxia, anyone who doesn't have enough oxygen. So trouble breathing, accessory muscle use, labored, SpO2 below 94%. That would all indicate hypoxia, low oxygen. That would be the indication. A contraindication would be that you didn't have any of those things and that you were just giving it to give it. We do not just give it to give it. Oxygen is a drug. It is a medication. And overusing this medication causes bad things to happen inside of our bodies. So the contraindication would be that you don't have hypoxia. You know that the dose is 2 to 15 liters per minute based on the patient's condition. Are we needing a cannula? Do we need a non-rebreather? Do we need a bag valve mask? That would determine my flow rate so that the dosage is 2 to 15 liters per minute. Obviously, they're going to inhale it. You need to take note of the routes and make sure you know what routes are. We're going to explain them. Okay, so that is oxygen. Aspirin and nitro are together because they're typically given together. You almost always would be giving both of these to chest pain patients that you believe are experiencing some type of cardiac event, that you think this might be a heart attack. Those people should receive aspirin and nitroglycerin as long as it is safe to do so. And by safe, I mean that they don't have the contraindications listed here. The contraindications to aspirin and nitro are more absolute. They are not relative. If you had these things, you would not give these two medications. Aspirin and nitro are indicated for chest pain. You would not give anyone who was bleeding actively aspirin. You would not give anyone with a low blood pressure or taking sexual enhancement drugs nitroglycerin, because nitroglycerin lowers blood pressure substantially. Sexual enhancement drugs like Viagra were not invented for sexual enhancement. We found out accidentally that drugs like Viagra, which are phosphodiesterase inhibitor 3s, you don't need to know that, we found out that they, as a side effect, cause priapism. Priapism is a sustained erection. What they were actually invented for is pulmonary hypertension, where the pressure inside the pulmonary vessels is so large that blood cannot go from the heart to the lungs. obviously that would be a pretty devastating condition. One of the largest populations of patients who experience this condition are neonates, brand new babies. Viagra is given to brand new babies. You probably didn't know that. So females can be on Viagra. Men, obviously, can be taking Viagra. Neonates, little babies, can be given Viagra. You need to know that. You need to know that if you give nitroglycerin to someone who has had Viagra in the last 24 hours, that it will substantially increase the chance of very low blood pressures. It's doubling the effect, if not more. You would not want to ever give nitroglycerin to someone who's been taking a phosphodiesterase 3 inhibitor in the last 24 hours, like Viagra, Cialis, Levitra. All of those drugs are commonly taken by men for the purpose of treating sexual disorders. But their main reason for existing is to treat pulmonary hypertension. So you need to pay attention to female patients that you give nitroglycerin to as well. Maybe you don't say, ma'am, are you taking Viagra? Because that would be confusing to most people. What you might say is, ma'am, do you have pulmonary high blood pressure? Which means high blood pressures inside of the lungs. Have you ever been told that you have high pressures in your lungs? And if they say yes, then there is a potential that they also, too, could be taking Viagra. Nitroglycerin's job is to open up the blood vessels and let more blood go by, thereby letting more oxygen get by. Aspirin's job is to thin the blood. That's not necessarily true, but it is an easy way to understand it. It is an anti-aggregant, which means it keeps the blood platelets, the little parts of your blood responsible for clotting, it keeps them from sticking to each other, or also known as aggregating. So aspirin's job is to thin the blood, and nitroglycerin's job is to open up the blood vessels. So now I have blood that isn't as thick and vessels that are bigger, so the hope would be that more blood would go by, allowing the tissue that's in trouble from a blockage to get more oxygen. In a heart attack patient, a heart attack occurs because the arteries that feed the heart, known as coronary arteries, they become blocked. And when they become blocked, it results in chest pain because when tissue doesn't receive oxygen, it makes you experience pain. If that pain is being caused by an artery that's closed, then aspirin and nitro should relieve the pain. Because when you open the vessels, when you thin the blood, more oxygen gets to the area that wasn't receiving any, and the pain level goes down. If that were true, you would know that you're successfully treating a patient who seems to be experiencing a heart attack. So we wouldn't give aspirin to anyone with GI bleeding. We wouldn't give nitroglycerin to someone with a low blood pressure, less than 100. The dose of aspirin is 324 milligrams, but that comes in 4 81 milligram tablets. You will not find chewable aspirin in 324 milligrams typically. You would find it in 81 milligrams times 4, which is equal to 324 milligrams. So when you say what is the dose of aspirin, some of you are going to say 324 milligrams, and I'm going to say, well, how would you have arrived to that? And so if you take a look at chest pain aspirin ASA, by the way, is the abbreviation for aspirin. You don't need to know that necessarily. It would be a good thing if you did. You'll see that it is called baby aspirin. It's called low-dose aspirin. It's called chewable aspirin. The headache version of aspirin comes in 325 milligram pills. And you would swallow those pills. That's not the aspirin we want for a chest pain patient, because when you swallow a medication, it takes 30 to 45 minutes to work. When you chew a medication up and it is exposed to the oral mucosa, the mouth, that takes about 5 to 10 minutes to work. That is why we use chewable aspirin, also known as baby aspirin, to treat chest pain patients. I've been saying baby aspirin to my students for 10 years, and no one had ever had a problem with that. Until one year, one of my students said, well, you'd give them pediatric aspirin. And I said, there is no pediatric aspirin. And he said, yes, there is. You said baby aspirin. That's not what baby meant. The adult size of aspirin, the big aspirin, is 325 milligrams. The baby aspirin is 81 milligrams. We just meant lower dose. You, in fact, cannot give aspirin to children. It actually is very dangerous to give aspirin to children. There is no pediatric aspirin. If you hear someone say baby aspirin, they just mean 81 milligram tablets that are chewable instead of 325 milligram tablets that are swallowed. So for the chest pain patient, we're going to administer 324 milligrams of chewable aspirin by taking 4 81 milligram tablets that are chewable and giving it to the patient. They will chew it up so that it becomes an oral mucosa route, not stomach, which takes a long time. Okay? Nitroglycerin will be given in 400 micrograms, that's what that is, 400 micrograms, which is the equivalent of 0.4 milligrams. It will be given in a spray version, typically in a spray. Now, you can do little under-the-tongue tablets, but typically we see it in the spray version, which is this bad boy right here. This is a very common version of nitro. I don't know why my computer's taking so long. But it's this guy right here. That's what you're going to find on your ambulance. That's what you're going to have available to you. You would spray that under the tongue. And sublingual means under the tongue. That's what sublingual means. Epinephrine is given for anaphylaxis. We will define anaphylaxis later. The chest pain contraindication is very relative. It is not absolute. It would not prevent you from giving epinephrine to an anaphylaxis patient. The dose is 0.3 milligrams for adults and 0.15 milligrams for children. You will never ever write a decimal without a 0 in front of it. You will never ever write the dose of a medication without the increment. The 0.3 is the number amount, and the milligrams, mg, is the increment. If I ask you on a quiz, what is the adult dose of epinephrine? The answer is not 0.3. The answer is 0.3 milligrams. You can write that out, or you can do the appropriate abbreviation for milligrams, which is mg. Up in the nitro, we saw that mcg is micrograms. If you know already, micrograms are 1/1000th of milligrams. And so all you've done is move the decimal 3 places to the right. If you're going from milligrams to micrograms, go 3 to the right, and that would give you 400 micrograms. If I'm going from micrograms to milligrams, the decimal is on the end of the 400, so I would move it 1, 2, 3 places to the left, and that gives me 0.4 micrograms. And epinephrine would be given intramuscular, which means into the deltoid, which is the shoulder, the lateral part of the shoulder that you feel when you touch someone's arm, or the lateral thigh, the middle of their outside thigh. Activated charcoal, I'll let you read, but it isn't real. We don't really do it, but you could do it. It is an EMT drug. We give activated charcoal to bind with agents that are in the stomach that are poisons. So it's given for poisoning, and basically we want the charcoal to bind with the poison and not let the poison get absorbed by the body. So take a person who takes a lot of Tylenol, we could give that patient activated charcoal, and then the Tylenol wouldn't get a chance to harm the patient. That's not necessarily true. That's why this drug is very unfavorable. And so you don't see it given a lot. However, it does find its way onto the National Registry Cognitive Exam a lot. So you must know it. It's 1 gram per kilogram. That question is always on quizzes. It's always on tests. It's always on the National Registry exam. So then you must know it. So the average patient weighs 100 kgs. Then the answer would be 100 grams would be the dose of a normal patient. The question that typically comes your way is, the patient weighs 25 kgs, how much activated charcoal will you give them? The answer is, I'd give them 25 grams of charcoal. You need to know the increment. 1 gram per kg, not 1 milligram, not 1 microgram per kg, 1 gram per kg, G-R-A-M. The route is obviously by mouth. They would ingest it, they would swallow it. Narcan is given to opiate overdose, also known as pain medications. So morphine, fentanyl, Dilaudid, heroin. Write that down. These medications are the only medications that your Narcan will treat. Narcan will not reverse an overdose of any other type of medication except opiate medications, which are pain medications, oxycodone, hydrocodone, Lortab, Darvocet, Percocet, heroin, fentanyl. Those types of medications make patients go to sleep. They make patients not want to breathe. They pinpoint the pupils of the patient. There is no contraindication in Narcan. It's a pretty safe drug. If they weren't overdosing on opiates, then nothing would happen if you gave Narcan. If they are responsive to Narcan, then it has to be an opiate overdose because no other medication will be reversed by Narcan. Narcan's brand name is Narcan and its generic name is naloxone. It comes in both of those names, and so you must know both of those names. We give it intranasally with a Narcan atomizer. There's a picture in your book of someone receiving Narcan by atomization. This picture right here shows you the Narcan being atomized by the atomizer. This little ditty here is pretty common by police officers and firefighters who also carry Narcan. And so if you push the bottom of this, it immediately atomizes 4 milligrams of Narcan into 1 nair. This version is more successful than the Narcan that you will carry, which is this. And that is because This is a higher concentration of Narcan, which is appreciated more by the intranasal route. We'll talk a lot about the intranasal route. It is a good route, but it is a route that requires knowledge and discipline. If you just go squirting medications up patients' noses, it will not work. It is a finicky route. It is a route that requires a lot of knowledge. So we will talk about how to get medications that are given through the intranasal route to actually work. You will find out that most people do not believe given intranasal Narcan works, and they are wrong. Intranasal Narcan absolutely works if you give it correctly in a high concentration. This box is the most common concentration that you see, and you can tell that it's 2 milligrams in 2 mLs. You can only squirt 1 milliliter of fluid in someone's nose. If you went with any more volume than that, it would just run down the back of their throat and they would not get that medication through the Narcan nasal route. But if you look over here, you see 1 cc holds 4 milligrams. That would be a more effective dose in the intranasal route because there's more medication in the same amount of volume. Over here, it was 2 milligrams per 2 cc's. That's 1 milligram per ml. Over here, it's 4 milligrams per ml. That is a better dosage concentration if you're going to use the intranasal route. We will talk a lot about that as we go on. So that is how you will give your Narcan. And in the chapter 12, you will find on page 515, they're giving intranasal Narcan to a patient on the bottom of the page in 12.9, figure 12.9. Albuterol is for wheezing on lung sounds. You would have to listen to their lung sounds and you would detect wheezing and then you could give albuterol. There's no real contraindication to albuterol. There's 2 ways to give albuterol. A metered dose inhaler, that's what MDI stands for. You're going to get quiz questions from me that simply say, what is an MDI? Please know what an MDI is. If you look on page 517, on page 517 in your book, there is a meter dose inhaler in figure 12.11. It is the little L-shaped inhaler that you commonly see. This is a meter dose inhaler. You would just give puffs of this. 1 puff every 5 minutes would be common. If you were going to nebulize it, which is in figure 12.10, you would squirt 2.5 milligrams in the little cartridge at the bottom. And you would turn the oxygen up to 6 liters per minute, and it would nebulize. You'd put this on a mask and give it to the patient. So in this picture here, you see a patient who's receiving nebulized albuterol. In the EMS environment, you have 2 ways to give nebulized albuterol. You can do it in the mask, like this version here, which is the non-rebreather mask. Take the bottom of the non-rebreather mask out and put the cartridge you see in figure 1210 on page 517 in the bottom of the mask, which is this guy's hand. What this guy is holding in his hand can go in the bottom of a non-rebreather mask. Or you could let the patient hold it, like you see here in the picture. Most commonly, the patient will be in enough distress that you want to give it like this lady is receiving it, because they don't have to necessarily hold it if you do it that way. You need to remember both ways. Meter dose inhaler, 1 puff every 5 minutes, or nebulized in a nebulizer with a non-rebreather mask. You hook the bottom of the nebulizer cartridge to oxygen, and you turn the oxygen to 6 liters per minute. Any higher than that results in a larger atomized molecule, and the patient doesn't receive the medication. Any lower than that won't be enough to atomize the medication at all. So 6 liters per minute is a sweet spot. You hook the nebulizer up to oxygen at 6 liters per minute. Now they're receiving oxygen and they are receiving the medication. I will simply ask you a quiz question that says, if you are nebulizing albuterol through a non-rebreather mask, what liter flow is your oxygen set at? Yes, Vishnu? I think that was a mistake. And the answer would be 6 liters per minute. You got to remember both ways of delivering albuterol on page 517. Oral glucose is given for low blood sugar, which is less than 70. The big word for low blood sugar is hypoglycemia. If a patient was hypoglycemic, they could receive oral glucose. You would never put a medication in someone's mouth if they weren't awake, alert, and able to follow commands. The best way to know if someone can clear their airway is, are they awake and do they swallow upon your command? Do not give oral glucose in someone's mouth if they are not awake and they cannot swallow upon your command. We typically would give 15 grams at a time. That comes in tablets and it comes in tubes of gel. So this little nasty gel, if you've ever had candy gel, it's the same thing, except medical grade. 15 grams of sugar is pretty low. An average Pepsi Cola, for example, has somewhere around 60 grams of sugar in it. So all this is sugar. You would give it to someone who is low sugar. The route is buccal. Buccal means in the cheek. You would not say that the route is by mouth because that means they've swallowed the medication. I want you to know that routes have times associated with them. If the patient swallowed the medication, then it would take about 30 minutes to work. If the patient moves the medication around in their mouth, then it will take about 5 to 10, maybe 15 minutes to work. So buccal is the route, not the enteral, E-N-T-E-R-A-L, route of swallowing. Enteral means to swallow. Buccal would be moving that medication from cheek to cheek around the oral mucosa. If you look on page 498, figure 12-1 shows you the quickness or the slow nature of any given route. You're going to see test questions that just ask you which one of these routes would be the fastest delivery of medication. Pay attention to the table 12-1 on page 498. The medications that we've just gone over are the core medications that you are responsible for in this class. You are also responsible for the medications on 508 and 509 that are not listed here, but these are the rescue medications. These are the important, the urgent, the emergent medications. Oxygen, aspirin, nitro, epinephrine, activated charcoal, Narcan, albuterol, and oral glucose. Memorize them. Make flashcards. Make flashcards about their drug names. Make flashcards about their indications and contraindications. Make flashcards about their dose. Make flashcards about their route. Know that I will not accept a number for a dose. It must be the number correctly written with the correct increment. Let's take a break. We will come back at 8 p.m. Grab you some food. Grab you some dinner. We will come back at 8 p.m. We will quickly go through the chapter material of Chapter 12. And then we will move on to the medical module overview chapter. I will see you back here at 8 p.m. Okay, everybody, welcome back. Go ahead and put your hands up, please. Thank you. Okay, we are recording. We are screen sharing. We have 18 people out of 23. I need Hernandez is here. Bang, Ryan Jackson, are you back? Okay, so Bang, we're just missing you. We'll see if you come in a couple seconds. If you do, speak up. All right, double checking the other side. We are screen sharing. We have volume on and we are recording. Okay, let's quickly go through the slides related to the chapter on pharmacology. We've covered most of this, but we definitely want to get as much of this information in as we can while you have FaceTime with me. And so I'm going to pull this over so I can see. To get that. Type chat. I see, Bang. All right, kids. You should be able to see my slides. If you can't, speak up. I'm going to go through quickly and tell you the additional things you need to know about pharmacology, and then we're going to move on to the medical overview chapter. I am going to talk a lot about medication safety. I'm going to reference a case for you that I want you to go look up about medication safety. I'd like to speak on the point that medications are probably one of the most litigated events in medicine. There's a lot of potential to do harm with medications if we're given the wrong drug, given the wrong dose, given the wrong route. All the different ways you can mess up giving a medication. So we have to have systems in place to be careful with medication administration. You cannot take back a drug that you've given. It's very important that we have a safety culture built around the administration of medications. And the fact that we really can kill people when it comes to medication. And so, touching on that, I'd like to take you over to the Vanderbilt case. Vanderbilt nurse kills patient. So, this is Redonda Vault. Redonda is a fairly young nurse. She was supposed to give a patient who was going for imaging. They were going to get some radiographical imaging, and they were nervous. So she was supposed to give the patient Versed, Versed, to calm them down. Versed is a medication that calms you down, makes you feel better. Instead, Redonda gave vecuronium. Vecuronium is not a sedative. It does not make you feel better. It paralyzes your whole body. So she thought she'd given a drug that made the patient sleepy and feel better. She'd actually given a drug that kept the patient fully awake, but completely paralyzed from head to toe, and that patient did die. This case is a very good case to show the importance and the power behind the patient's rights. The patient has rights in regard to medication. In general, those rights are designed to protect the patient from having incorrect medications given to them, incorrect dosages, incorrect medications, whatever the case may be. We've identified that medications are dangerous. We've identified that this is an area that can kill our patients instead of make them better. We know that our biggest goal is to do no harm to people. So if that's true, then we have to build a system in place to protect the patient. And if you're looking on page 503, table 12-3 gives us the patient's rights. That we have the right patient, that we have the right medication, that we have the right dose, the right route, the right time. Those are the 5 that we're going to talk about. It goes on to say right education, right to refuse, which patients do have, the right response to the medication that we were giving, and that we are going to document the medication appropriately, accurately. The ones I want you to focus on are right patient, right medication, right dose, right route, right time. Redonda violated right medication. There were some systems available to Redonda to make sure that the drug she intended to give was the drug she actually did indeed give. She didn't use those systems, which brought about criminal charges and civil charges and the loss of her license. In the back of an ambulance, the systems that you will have available to you to make sure that your epinephrine that you want to give the patient is indeed epinephrine will be different from agency to agency to agency. There is one system for which you could employ that will always make you successful. And it's on page 505, called the Medication Administration Cross-Check. We are humans. Humans, even the most educated and the most well-intended, make mistakes. If Rodonda had showed the vial of medication in her hand to another nurse, there's a good chance they would have said, Rodonda, that is not Versed, that is vecuronium. And vecuronium will kill the patient. We do not give medications to patients unless someone agrees with us that the medication in our hands is indeed the medication we mean to give the patient. That is called cross-checking. On page 504, right medication means is what you have in your hand what you mean for it to be. A safety culture around medications. That is what we have to build. We will get into this more elaborately, but I want to make very clear to you that when you're reading this chapter, when you're learning about these medications, you need to do so with the discipline that this is an area that can kill your patient. Your mistake could cost them their life. I want you to keep that in mind. Moving on to this slide that's before you, you can give medications as an EMT via these ways. You can self-administer the medication. That's when you're going to give the medication. You can peer administer the medication. And you can assist in giving the medication. Make sure you look into the definitions of those three versions. Most commonly, the EMT in current scope will be giving medications of their own accord. 10 years ago, EMTs would most likely have been giving medications that the patient was already prescribed, and the patient had that medication with them. Today, we send EMTs out on ambulances with a bag of medications, and they can select from that bag the medication that they feel is indicated, but not contraindicated. They can go through the 5 rights, right patient, right medication, right dose, right route, right time, and they can determine that this is the medication they want to give on their own accord. That is a fairly new, in the last 5 to 10 years, concept for the EMT scope. You no longer are just assisting with the medications that the patient was already prescribed. For example, they would have their own EpiPen. They would have had their own nitroglycerin. So you're merely just saying, hey, it's probably a good idea, let's do that now. That's not the case today, where you're giving your own medications. And so that's something to think about. We talked about medications names, brand name versus generic name. Medications do have effects and actions, meaning what do we want from them? Indications is why we give it, and contraindications is why we shouldn't. We discipline that word contraindication even further by saying there are absolute contraindications, like putting a medication in the mouth of a patient who's unconscious. But most contraindications are relative, meaning do they apply right now? Is the risk of giving the medication so big that it outweighs the benefit? That's the difference between an absolute contraindication and a relative contraindication. The routes of administration, we know that if we look in our book on page 498, the routes most common to you are sublingual, which means under the tongue. By mouth, which means to swallow, that takes about 30 minutes. That's a slow route. Inhalation, like albuterol, they're going to inhale it. Oxygen, they're going to inhale it. Intranasal is really rapid. That's for Narcan. Intramuscular, that's when we inject a medication into the muscle via a needle. Those are the routes most common to you. Take a look at table 12-1 on page 498 and familiarize yourself in-depthly with the routes. Side effects are things that happen because we gave a medication. They're not necessarily good, but they're not necessarily bad. Please understand the difference between a side effect and an untoward effect. A side effect is something we kind of knew might happen, but would be best if it didn't. A side effect of antibiotics is diarrhea. We wish it didn't happen, but it's just a part of taking a diarrhea. Taking an antibiotic, that you're going to get diarrhea. An untoward effect would be something that's really, really bad that you didn't expect to happen. Example, we give someone an antibiotic and they stop breathing. That would be very untoward, meaning we didn't think this was a common response, a very negative response. That's the difference between side effect and untoward. Side effects are dizziness, nausea, sleepy, diarrhea, upset stomach. Untoward effects are really bad, like if I had given a patient albuterol and their blood pressure dropped really low, that wouldn't make sense. It would be untoward, it would be bad. Interactions, some medications don't like others, and we've got to memorize the dosages of the medications that we give. Pharmacology is the study of all things related to medications in the medical world. That's a test question. This slide is really important. Agonist, to agonize, means to make worse, to do more of the same. If I agonize you, then I make whatever is happening worse or more of it. That's an easy way to remember agonist. So, example, if I gave you fentanyl and Benadryl together, fentanyl has its own punch. Let's say that it is a punch of 5 on the scale of 0 to 10 in punches. So it's a 5. If I give it with Benadryl, it has a punch of an 8. So the Benadryl is an agonist to the fentanyl. It made one medication stronger than it normally is. So the medication is already strong, and it now makes it stronger. So that's an agonist. An antagonist actually reverses or does the opposite of. Narcan is an antagonist to opiates. Narcan reverses morphine, fentanyl, heroin, Percocet, Darvocet, Lortab, hydrocodone, oxycodone. It is an antagonist. It goes directly against. So if I were you, for agonist, I would put goes with, makes more of a desired effect. An antagonist directly contrasts. It blocks. It reverses. It goes against. You understand dose? Action is what I want from the drug. What effect is it going to give me? Onset is how long will that take? Routes of administrations need to be attended to by you. We already talked about generic and trade. Remember that over-the-counter medications are just as important as prescribed medications. They can cause harm. They do cause harm. Herbal medications can cause harm. They do cause harm. So when we look at sample, signs and symptoms, allergies, medications, we want all of it. Do you take any drugs or alcohol today? Have you had any herbal medications, any type of over-the-counter medications? Have you taken any prescription medications? What medications are you on? That is all encompassing in our M of sample. Enteral means to go inside. That makes sense, right? Enteral, inside. So you swallow it. Parenteral is everything else. We do need to discuss absorption again. Charcoal, for example, activated charcoal, is an absorption medication. To prevent absorption, it has to adsorb. Okay? So it binds itself to the bad stuff to prevent the body from absorbing it. So if you were to give charcoal a designation, you would say it is an adsorbent. It adds itself to the bad stuff to prevent absorption. AB, as in Bravo. That's going to be a test question. How does activated charcoal work? Well, it adds itself, it binds itself to the bad stuff to prevent the body from absorbing the bad stuff. Per rectum, you can give a lot of medications per rectal and per vaginal. Most commonly, per rectal medications would be to treat seizures, especially in children. Because parents aren't educated in starting IVs or starting an IO, which is accessing the venous system and accessing the bone system, they don't have that training. They can't do that. So how do we get these really important medications on board? Well, we can train someone to squirt medication up the rectum pretty easily. And it's quite effective because the rectum is a mucosal membrane, similar to the sublingual route, similar to, which means under your tongue, the buccal route, which means in your cheek. So all mucosal membranes, like the buccal and sublingual route, like the per rectum route, are pretty quick administration routes. If you're looking at table 12-10498, you'll see that per rectum is considered rapid. That is why all of those college kids a few years back were dying, because they were taking tampons, dipping them in 100 proof alcohol, and then inserting them rectally. They did not realize that the concentration of alcohol is very high, and you're used to metabolizing that concentration through the PO route. The PO route, which means to swallow it, takes a very long time to metabolize whatever it is that you swallowed. But the per rectum route can metabolize what you have inserted very quickly. And so a lot more of alcohol was absorbed a lot more quickly. The dose is much higher in per rectal administration, the received dose, than in the PO route. If I was going to give something PO, I would give 1 milligram of it. If I was going to give something per rectum, I might give half of that, because the rectum is so much more quick in route and it is so much more efficient as a route. So these things matter, and those kids died. So we got to remember that these routes are very important. How fast are the routes? What routes are available to me? What is sublingual? What is buccal? What is PR? What is PO? You should make flashcards for those. Intravenous obviously means into the vein. That would be a paramedic or an advanced EMT. IO would be into the bone space. That would be a paramedic or an advanced EMT. Those are very, very fast. They're almost immediate routes. Subcutaneous, you guys really don't use. That would be a medic thing. Intramuscular is an EMT route and above. Epinephrine is the most common intramuscular medication for you. Sublingual under the tongue again. Intranasal into the nostril. We'll talk more about intranasal. There's the 12-1 chart. It will give you a couple questions about how drugs are formed. And what I want to bring your attention to is this slide in particular. A solution does not require mixing. It is mixed and it will always be mixed. A suspension, if left alone, would separate. You must shake a suspension before giving it. Activated charcoal is a suspension. If you didn't shake activated charcoal very well, you would not be giving the medication, you would be giving the delivery drug. which would typically be some type of solution. Antibiotics are very commonly suspensions. They require shaking. The medications will separate from the liquid. So you have to shake them. So remember, a suspension must be shaken. It will separate. I already talked about a metered-dose inhaler. This is oral glucose. Again, comes in tablets, comes in tubes, typically about 15 grams. You guys know how to give medications through non-rebreather mask, through a nasal cannula. You now know about nebulizing albuterol through a non-rebreather mask. Can anyone tell me what liter flow you would nebulize albuterol? 6 liters per minute. Thank you very much. I need you to commit to memory. Right patient, right medication, right dose, right route, right time. The other ones are important, but the right patient, right medication, right dose, right route, right time is to be done in the moment of giving a medication. The rest of these are acknowledgments lateral to the administration of a medication. Sure, you have to be educated on that medication. Sure, the patient has a right to refuse. And then making sure the patient has the expected response and reassessing a patient after administering a medication is very important. So is the documentation. However, those last 4 are not acute. You must verify right patient, right medication, right dose, right route, right time before giving an actual drug in every exam that you do in the class. And more importantly, in every patient you care for in real life. We need to define what these terms mean. Right patient. What is right patient? So let's define those things now. If you're taking notes, beside right patient, you should put indicated but not contraindicated. The right patient in our setting is a patient who should receive this medication because of their chief complaint, because of their presentation, because of our assessment findings, and that there is no contraindication so big, so important, that we would withhold that medication from that patient. Right patient simply means it is indicated and not contraindicated. The way you would demonstrate knowing this in the classroom is you would say, Justin, I would like to give the patient aspirin. I know that this is the right patient because the patient has chest pain. They are not the wrong patient because they do not have any GI bleeding. So they are the right patient. Is it indicated and not absolutely contraindicated? Right medication is you verifying by looking at least 3 times yourself and cross-checking with your partner that the medication you think you have in your hand is the medication you actually do have in your hand. Right drug is the cross-check method. Partner, is this epinephrine in my hand right now? That might sound silly. Might sound silly, folks. But it ain't silly to Redonda. It ain't silly to her. She lost her freedom. She lost her job. She lost her license. She lost financial stability. But most important, she lost her ethical commitment to do no harm to her patient. That's what Redonda lost when she killed her elderly patient by failing to verify that she had the right medication. Right dose is simple. Do you know it or don't you? Right route is simple. Choose the route that is most appropriate for your scope of practice and that particular medication. Right time is a critical thinking component. Should I treat for shock first or give epinephrine first? Most commonly, you would treat for shock first. No one tends to die so fast from anaphylaxis that you don't have time to throw them on oxygen and treat the patient for shock as best you can. That would typically be the course of action. Treat for shock and then give epinephrine. But maybe that isn't the case. The patient is dying so quickly that epinephrine is the most indicated time. Another example of right time is that Narcan does not save the life. Hear me, church. Narcan does not save the life of an apneic overdose patient who is overdosed on an opiate. Good management and control of airway and breathing, that is what saves the overdosing apneic patient who has overdosed on opiates. It is not Narcan. It is not the right time to give Narcan if you have not maintained A and B. If you gave Narcan before you managed A and B, I would fail you. If you were employed by me and you had a habit of giving Narcan before managing A and B, I'd fire you. It would not be the right time. People will die if you focus on Narcan over breathing for them. That's the emergency. The apnea is the emergency. Fix it with a BVM. Then, when able, when appropriate, when indicated, choose the right time to give Narcan. Any questions about the 5 rights? Right patient, right drug, right dose, right route, right time. If you told me the route for oral glucose was PO, because if you look on 508, you look on page 508, and you go down to the oral glucose, and I'll be damned if they didn't put PO. They sure did. There it is, PO. That's not correct. Swallowing that medication would increase the time of absorption versus the buccal route, B-U-C-C-A-L, being swished around the mouth and allowing the oral mucosa to absorb the medication. So I disagree with the chart on 509. It should say buccal, it should not say PO, and that is important. Any questions about the 5 rights? All right, let's continue. Remember not to give oral medications to someone who's not alert and able to swallow by command. Sublinguals under the tongue, typically we're talking about nitro, spray, and tablets. Most common that we would have the spray. Remember that it opens up the vessels. It lowers blood pressure. So I would never give nitro to a low blood pressure patient. I would reassess the patient's blood pressure every time I gave nitro. If you give nitroglycerin in the class before checking a blood pressure, you are failed. If you fail to reassess a patient's blood pressure and pain score 5 minutes after giving aspirin and nitro, you fail. Because you do not know the effect of the medication you gave. Just as important as checking to make sure you should give a medication and then doing so, it is just as important to reassess the effect of that medication and to know which things to reassess first. If I gave nitro and aspirin, I'd want to reassess blood pressure first. I'd want to reassess pain score first. Because those are the things affected by the medication. I'll let you read the rest of that. Epinephrine makes our lungs breathe better and our heart work harder. It makes the tank squeeze. Epinephrine does all three of those things. It is an alpha and beta property medication. It is naturally occurring in the form of adrenaline, secreted by your body's own sympathetic system. We have the ability to give this medication to people that they already have in their body, but they don't have enough of it. So we're going to give it more. We're going to supplement what they have. So the adrenal gland secretes epinephrine. Well, I'm going to give them epinephrine. The entire goal of this epinephrine is to make the lungs open up and breathe better. Make the heart beat faster and harder. Make the tank squeeze. Anaphylaxis causes the opposite of all of those things. The lungs close. The airways close. The tank opens up, and so the blood pressure goes to crap. The heart can't beat fast enough. It can't beat hard enough. So we give epinephrine, which makes us breathe better. It opens up the airways. It makes the heart work harder, squeeze faster. And it makes our tank squeeze as well. Don't just know what medication to give. Know why. Know why to give it. Narcan, also known as naloxone. The naloxone here should not be capitalized. It should be lowercase. It's only capitalized because it's a bullet point. But if it was being most accurate, it would be lowercase because it is a generic, not a brand. Naloxone would be given intranasal. In some states, like ours, you can give it intramuscular. There is an auto-injector pen of Narcan, just like there is for epinephrine, but they are quite expensive. It is cheaper and arguably, if done correctly, just as effective. And that is an argument. There are a lot of variables in that argument. But you could give both of those medications intranasally and intramuscularly. It's not very common for Narcan to be intramuscular for EMT in our state. Although it is an option, it's not common. It is most common that Narcan would be given intranasal. So then you must know how to give a medication intranasal. We will speak in lab, where we will practice Narcan and epinephrine, about how to give a medication in the intranasal route. Here's an example of that being done semi-correctly. Some of what they are doing right now is incorrect. And we will talk about it later in lab, where you can get a visual. We know about oxygen. I already showed you that. We know about MDIs, meter dose inhalers. I already showed you that. We discussed the power of a medication error before you give a medication in this class. Before you give a medication in this class, most importantly, in real life, you must out loud, audibly, physically go through each part of the 5 rights. Justin, I will give aspirin because the patient has chest pain and no bleeding. I will give 324 milligrams of aspirin, which is 81 milligram tablets times 4. The patient will chew these tablets up. The right time to give it is right now because I'm in the secondary exam. We are going to the hospital emergent. We've already treated the patient for shock, so this is the right time to give that medication. That's right. Medication by taking the bottle and showing it to my partner and saying, is this aspirin? What I just did is went through the rights. And now that we have, it's safe to give the medication. What is the answer to this question? The study of drugs and medications. Very good. Which one of these is not true? C is not true. Over-the-counter medications can be purchased at will. They don't require a doctor. Which of these is the fastest route? Bravo, very good. Intravenous is the fastest in that category of those listings. Metered dose inhaler, how does it work? Metered dose. Yeah, every time you squeeze the little puffer, it's going to give the same amount of dose. Crushing chest pain, low blood pressure, tachycardia. They want to give nitro. After receiving an order for nitro, what would you do? Considering that blood pressure. Yeah, I'd repeat that back to the physician again because clearly they did not hear you. It's easy to hear 184/64 versus 84/64. We know that if it was below 100 systolic, we would not give nitro. So clearly there's been a miscommunication, and you should repeat the blood pressure back to the physician and give them a chance to correct the order. If they didn't, you would not follow a conscious, incorrect order, an order for which you don't think is wrong, an order for which you don't feel like might be wrong, an order that you know objectively is wrong. And giving nitroglycerin to a very low blood pressure is objectively wrong. How does activated charcoal work? D. It adds itself to the chemical. It binds itself to the chemical, thereby attempting to reduce or prevent absorption. What is action again? What do we want it to do? Delta, the effect of the drug. Who should get oral glucose? I agree with A. It's between A and C. The problem with C is that the patient has a high blood sugar, so I certainly wouldn't give more blood sugar. So A is the conscious patient with a low blood sugar. They should get oral glucose. B and D can't get anything oral because they are not awake, they are not alert, they cannot swallow upon command. What does epinephrine do? To dilate means to open, constrict means to squeeze. Bravo is the answer. We would open the bronchioles. We would constrict the vessels. The process to make medications work. C. Charlie. We absorb them. Not A, C. Very good. Probably one of the most important chapters in the book, given its significance. Let's take a 10-minute break. 10-minute break, and we will come back and finish with chapter 15. 10 minutes. let's go over to the medical overview chapter. Basically, this chapter is telling you what you're about to see in the medical module. I like to call the medical module the ingredients to soup chapter, because every diagnosis that you can think of, every actual diagnosis of what is wrong with a person, comes from the commonality, the statistical expectation of complaints, signs, symptoms that the patient tells us about, presents with, shows us in our assessment. It is not magic. If you've ever watched Dr. House, those weren't extremely brilliant people or portraying to be brilliant people, so much as they were people who had studied the ingredients of a set of given diagnoses. And how good you are at diagnosing a patient, which, by the way, the EMS verbiage for diagnosis is field impression. On next week's module exam, you'll be asked to define general impression versus field impression. Field impression is the EMS version of diagnosis, and all that it is learning, memorizing, understanding the ingredients to individual diagnoses. When we get to the cardiovascular chapter, it will list the most common cardiovascular emergencies experienced by our patients. And I will simply give you the ingredients. Here's what the patient would complain of. Here is what the signs would be. Here's what the symptoms would be. I remind you that a sign is something you can see and is objective. It is absolute fact. A symptom is a complaint of something. So an example of a symptom is nausea. I can't see nausea. I don't know that it is there. It is not absolute. I'm having to take the word of the patient. But vomiting, on the other hand, is a sign. I don't have to wonder if the patient is nauseous when I see a sign of vomiting. This entire module will be or won't be successful for you based on whether you are committed to learning the ingredients of a typical set of emergencies. For each individual system, we'll go through cardiac emergencies, respiratory emergencies, endocrine emergencies, immunological emergencies, obstetrics emergencies, environmental emergencies. And you will get these diagnoses correct if you have memorized the symptoms, the signs, the sample and OPQRST. Okay? Let's get into it a little bit. Obviously, we're finding out a chief complaint. Obviously, we're looking for signs and symptoms. We will go through all of the systems. You need to know which systems exist. You need to know what their systems are called. Example, if you are experiencing a blood emergency, that would be a hematological emergency. That verbiage must be familiar with you. Here is a wonderful table that should mean a lot to you. In every system, if people are dialing 911 for medical emergencies, this is the diagnoses for which they call for. These are the things that kill our patients. All you have to do, and it is a daunting task, but all you have to do is go out there and learn the ingredients. Let me give an example. Let's take asthma and contrast it with pneumonia. Both of those patients are going to present complaining of trouble breathing, also known as dyspnea. Dyspnea, difficulty, pnea, breathing. They're going to both complain of trouble breathing. I will use my sample and my OPQRST to decipher whether the patient is having trouble breathing because of asthma or having trouble breathing because of pneumonia. Asthma's onset is acute. Pneumonia's onset is gradual. Asthma will present with wheezing. Pneumonia will not, typically. Asthma may not respond very much to oxygen alone. Pneumonia will respond very quickly and aggressively to oxygen. Asthma patients will not present with a fever. Pneumonia patients will present with a fever. How do I take the generalized complaint of trouble breathing and narrow it down to a field impression that I can treat? You cannot treat asthma the same way you treat pneumonia. So then I must take my sample, my OPQRST, my knowledge of the anatomy and physiology of the systems, and decipher which is which. That's what this module is about. In the medical world, we're talking about natures of illness, not mechanism of injury. Nature of illness would be trouble breathing. Nature of illness would be altered mental status. Nature of illness would be seizure. Nature of illness would be my belly hurts. A nature of illness would be I got diarrhea. Those would all be natures of illness. I'll let you read through the material. I'm just providing you the meat and potatoes. Remember that a general impression, by definition, does not require you to put your hands on the patient. It is rapid, it is quick, and it is assessed from across the room. Airway and breathing, what is normal? What is abnormal? You need to get into that. You need to delve into that. We've talked a lot about that. You need to make sure you understand what normal should be and what abnormal looks like. What is shock? What are early signs of shock versus late signs of shock? Early signs of shock include anxiety, tachypnea, and tachycardia. Late signs of shock include cyanosis, low blood pressure, bradycardia, bradypnea, which means low breathing. Those would be late signs. Know what is early versus what is late. Unconscious people tend to need positive pressure ventilation. Conscious people tend to need non-rebreathers. That's just a known fact. Make sure you understand sample and OPQRST forwards and backwards. And understand what they mean. Signs versus symptoms. What allergies, if any, do you have? What medications do you take? That includes, have you had any drugs or alcohol today? Do you take any over-the-counter medications? Do you take any herbal supplements? Pertinent medical history. It is likely that what has happened to the patient before may happen again. Last oral intake is important for a multitude of reasons. Maybe that's why we have anaphylaxis right now. They ate a brownie and they're allergic to nuts. They didn't know the nuts were in the brownie. Maybe I'm worried about last oral intake because the patient is now unconscious and unresponsive, and that an unconscious, unresponsive patient cannot protect their airway. So if they were eating an entire meal and then became unconscious and unresponsive, I'd probably want to put them in recovery position, because a last oral intake that includes a big meal of a patient who's now unconscious should concern you about aspiration. Events leading up to tells us the story. OPQRST includes onset. Onset is either acute or it is gradual. It came on me all of a sudden or it came on me very slowly. Provocation and palliation. What makes it better or worse? I get more chest pain when I'm running than when I'm resting. I took 500 milligrams of Tylenol and now my headache is better. What makes it better? What makes it worse? Quality means to describe it. A person experiencing an abdominal aortic aneurysm will describe chest pain as burning and sharp and throbbing and stabbing. A person experiencing a heart attack will describe chest pain as a pressure, dull, achy, elephant sitting on my chest. Quality means to describe. Quality helps us differentiate one type of pain from another. There is a difference in organ pain, called visceral pain, and parietal pain, called cavity pain. If I currently have appendicitis, I'm going to have dull, achy, overwhelming pain in my right lower quadrant. If I have acute peritonitis, that's the cavity lining, I'm going to describe my pain as burning and severe and sharp. The pain of an organ system is not like the pain of a cavity system problem. Every part of you has a lining over the cavity. Those are called parietal linings. Every part of you has a visceral neurological lining and physical lining, and those are dull pains, achy pains. So quality is diagnostic. Quality is to describe. Chest pain that is sharp and burning and throbbing versus chest pain that is dull and achy and radiating. R is to radiate. If pain goes from one place to another place, that is statistical. It is common in specific diagnoses. So then we can use it to diagnose. Severity, 0 being nothing, 10 being the worst. Maybe that doesn't apply because it's not a pain and this is a trouble breathing. And so you say, have you ever had this happen to you before? Yes, I have. Well, how is this compared to the last time? Is this worse than the last time or is this better than the last time? That helps us judge severity. And then time is pretty easy. How long has this been going on? Make sure you are familiar with sample, OPQRST, AVPU, DCAP, BTLS. The secondary assessment's job, we know that it includes a lot of parts. Sample, OPQRST, it includes all the vital signs, and it includes giving medications for the diagnosis we have found, the field impression that we have found. It includes reassessing the patient every 5 minutes. It also includes the actual physical secondary assessment, the head to toe. The head to toe of going from the patient's neurological system all the way to the patient's peripheral nervous system and looking at PMS times 4, looking at the skin, looking at the patient's motor function. The head to toe assessment. Do you know how to do one? Because there's a video. I made a video. Have you memorized it? Do you know what to look for in each system? If I said, Noah, go over to Dylan and assess his HEENT, would you know how to do that? And if the answer is no, then you better not take that module exam until the answer is yes. What is Pearl? Those are the types of questions you're going to see on the upcoming module exam, and those are the important assessment components that are going to help you in the medical module. Vital signs, what are they? Blood pressure, heart rate, respiratory rate, SpO2, blood glucose. end-tidal CO2, temperature, pain score, pupils. Those are our vital signs. Do you know what they should be? What is normal? What is abnormal? If not, better look through your notes, because we've taken that amounts of information already and we've put it on paper. We've tried to learn to demonstrate it in class. Can you actually do them? Can you get a blood pressure? Can you check a heart rate and a respiratory rate over the course of 60 seconds or 15 seconds or 6 seconds? Do you know what those time frames mean or why I came up with them? Know that all transport locations are not the same. Hospitals are not all equal. Somerville Medical Center cannot take care of the same things that Trident Medical Center can take care of. Hospitals have things that they focus in, and they have things that they don't really focus in. If I have a trauma patient, I'd go to Trident. If I had an obstetrics patient, I'd go to Somerville. Somerville specializes in OB patients, even emergent OB patients. Trident does not. The burn center is at MUSC. It is not anywhere else. If I had a 1-year-old experiencing a level 1 trauma, severe trauma, I would go only to the Medical University of South Carolina. Not all hospitals are created the same. Learning what hospitals are around your response area and which patients to take where will be a part of your duties as an EMT when you go find a job. There will be guidelines and policies and procedures related to where you take people and how to critically think. Let me give you an example of the critical thinking that you'll have to do on a management side as an EMT. If you're at the College of Charleston and you're treating an anaphylaxis patient, you have called for ALS backup. That ALS backup is coming from Rivers Avenue in North Charleston. You have given the first dose of epinephrine to your patient, and they are not improving. Do you wait on your North Charleston ALS backup, or do you load and go as quickly as possible to the very adjacent Medical University of South Carolina? That is a critical thinking decision that you cannot put in a PowerPoint slide. You can't necessarily test it didactically very well. The variables and the critical thinking associated with being able to say it is time to go or we should wait, that is more complex than memorization and typical didactic training. Think about that. Scene times. The average scene time allowance for trauma is 10 minutes. You need to know that. No more than 10 minutes on scene for trauma. That's our goal. These are goals. Stroke patients, no more than 15 minutes on scene. That's our goal. Complex medical emergency patients, no more than 20 minutes on scene. That's our goal. These timeframes are directly associated with data that seem to indicate the patient's increase or decrease in mortality. We know that a trauma patient that is transported within 10 minutes inside of the golden hour of trauma has a better chance of survival than those whose scene time extended beyond the 10-minute allowance. So, trauma, 10 minutes. STEMIs, strokes, 15 minutes. STEMI is a heart attack. Stroke is what you know it to be. Other complex medical patients, no more than 20 minutes, like sepsis, patients who are super sick and have a very big infection. No more than 20 minutes. Basically, the point being, don't be hanging around on scene doing stuff that can be done en route. The general rule of thumb is, if you have in your bag and on your ambulance what will make a difference in the patient's survival, then it is okay to stay on scene and establish those interventions. If whatever will ultimately save the patient's life is not in your bag and not on your ambulance, then your most important goal is get the hell out of here. If you don't carry blood and you don't carry a surgeon, there is nothing more important than getting off that scene after you have treated for any bleeding or life threats and treated for shock. Nothing. If an IV needs to be started, it needs to be started en route. If the patient needs to be intubated and you're managing them well with a BVM and an OPA, then you can intubate them en route. And by you, I mean your partner, your team, your ALS backup. You do not sit on scene and do treatments that you can do en route that will not ultimately save the life of the patient. That's critical thinking. We reassess critical patients every 5 minutes. That's a test question. We reassess non-critical patients every 15. This is a helicopter from Scott's hometown. It's a 145, a beautiful aircraft. This is the same type of aircraft that I fly in. Pretty proud of it. It's really, really awesome. You guys can come out and see it. I've offered you to come. You can come anytime you want. Some of you have. Pretty cool. This particular one is out of IU Health in Indiana. I'll let you read that good stuff. It's all important, but it's just reading material. I'm not going to give it to you. You will get a couple questions on the differences in some of these infectious diseases. Herpes versus HIV. You need to know that EMTs face very little risk of contracting HIV in our setting. You need to also know that there are millions of HIV patients you will never know have HIV because people don't die from HIV. You take one pill per day and your HIV infection is controlled and your treatment is consisting of just that one pill every day. You will never be able to spread the virus. And if you are compliant with that medication and it continues to work, and for most people it will, you will never give that virus away. You have no risk of transmitting it and you have no risk of getting sick if your medication is working and you take that medication. So HIV risk has gone down substantially. So for a patient to tell you that they are HIV positive should mean very little to you, provided that they are taking their medication. And if they are, they cannot give it to you. So there's that. If a patient was newly diagnosed and isn't on medications, then that would be a risky patient. That would be a patient we would be careful with. But get out of your head that HIV is this life-ending situation. It's not. In fact, it's easier to treat than this one. It's easier to treat than this one. Easier to treat than diabetes, heart disease, pulmonary disease. So get out of your head that false information that you knew before this class. Hepatitis C does have a cure, but it is a tough set of circumstances. Main thing to remember is if you're wearing your PPE, you're not going to get these things, statistically speaking. Meningitis, you need to remember, is characterized by neck stiffness and blotchy rash. Neck stiffness. This is a patient who feels fatigued, they've got a fever, they've been feeling pretty horrible. Now they have neck stiffness because the meninges are inflamed, so it hurts to bend their neck because it stretches the meninges. The meninges are the layer that covers the brain and the spinal cord. And so if it's inflamed, because that's what ITIS means, then the patient will have neck stiffness and this red blotchiness. You'll have test questions about that red blotchiness. Whooping cough is pretty severe. It's very contagious, also known as pertussis, and you are vaccinated against it. It's included in your Tdap. MRSA is living around us all day. We know that we used to give antibiotics too frequently and for the wrong indications. And because we did, because we were handing them out like candy, a lot of the biological weapons formed against us, learned how to resist those medications. Nothing in life is free. Too much of a good thing is a bad thing. And this is the result of that thing. MRSA is typical in people's noses and on their skin. You can protect yourself by making sure to wipe down every piece of equipment that you use every single time, including your stretcher, your monitor devices, your ambulance. Then you don't have to worry about this. But if you do get MRSA in your nose, if you do get MRSA in a sore, you are looking at one hell of a fight. It is a very aggressive infection. Prevented by wearing your PPE, keeping a well-invigorated immune system, washing your hands, and cleaning your equipment. Tons of your patients will have MRSA. I'll let you read those things. What type of emergency is a seizure? It was in the chart, and it's a neurological emergency. Neuro means brain. Distracting injuries cause what? Sometimes we look over and we see the arm is gone. Oh, God, they're missing an arm. And that distracts us from the fact that there's this big old belly that's bruised and swollen and distended. And that arm that's ripped off ain't going to kill them because the arteries have already retracted in that arm. And they're not bleeding to death from their arm. They're bleeding to death from the big old distended belly that you missed because you were busy, distracted in your tunnel vision from a missing arm. Be careful with those types of distractions. They cause tunnel vision. A frequent flyer calls us all the time, but don't you ever take it for granted. What's the answer? Take the call seriously. Don't waste your time or resources on such a caller. Perform a primary assessment. He called for a head injury last week and it wasn't serious. Assume you know what the problem is. You should never assume you know what the problem is, so Charlie is the answer. Frequent flyers get us in trouble all the time. They've been crying wolf for a long time. So it's easy to go there complacent and think that today is another cry for wolf when there is no wolf. And then there will be, and you get sued. And I've always made the argument that if I'm going to go down for somebody, I don't want it to be the aggravating misuser, abuser of the system. These are the people you mind your P's and Q's with, because if you're going to go down, don't go down for these piece of craps. That's what I've always told myself, so I can behave well in front of a frequent flyer because I don't want to go down for them. They're not worth it. If they're not in critical condition, they're not having an emergency, we either load and go, or we stay and we play. So D, however long it takes you to do your job and to do it well, get their medications, get their home CPAP machine because they're going to be admitted, so you want them to have whatever they need at home. They're going to have to need it in the hospital too. If they have a walking cane, we get that. Maybe we call some family members and tell them they're going to the hospital. There's no emergency. That doesn't mean they don't need to go by an ambulance. That doesn't mean they don't have a medical reason to be seen at the hospital. But not having an emergency lets us spend as much time as we need to square the patient away. The answer to 5 is B. Respiratory difficulty is not responding to your treatments, so then you should be emergent. Emergent with lights and sirens. This is straight from the assessment module. Step 1 is scene size up, PPE, scene safe, BSI. This is the bad one. Which one of these is the real bad one? Hepatitis C is the bad one. 50% of all patients with Hep C will deliver chronic liver disease, hepatic liver disease that could result in hepatic failure. Cirrhosis is a hardening of the liver, basically prevents the liver from doing its job. It becomes fatty, it becomes stenotic. It's not able to function its filtering job. Very good. Blotchy skin, stiff neck, headache, feels bad. That's meningitis all day. Pulmonary tuberculosis. You think you've been exposed. What would you do? Go get a TB test. Bravo. Go get a TB test. Simple and it's quick. Risk factors for getting MRSA. We told you what MRSA is. Which one of these is not associated with MRSA? Yeah, it doesn't have anything to do with wild birds. Everyone loves to blame an animal. MRSA is secondary to the overprescribing of antibiotics, exposure to people who have MRSA, and being around the hospital environment where equipment is not being cleaned very well. Nothing to do with birds. Any questions about tonight? Covered a lot of material, important material. We're closing one module and we're opening the door to another. You have a ton of flashcard type studying to begin. And we opened the door to what the medical module will look like, what it will mean to us. There is a lot more medical patient population in the civilian pre-hospital world than there is trauma. That number in the trauma category is growing because of a multitude of reasons, but the medical patient is of much larger commonality in pre-hospital care. So some of you will like trauma better because it's physical and it's easier to diagnose. It is what you see. It is what you palpate. It is what you assess. But the medical will take thinking. It will take memory. It will take investigation. And some people just aren't good at that or haven't put the time in to memorize those ingredients to the field impression that belongs to the patient. Pharmacology, we've been very clear as to its importance and the overwhelming significance that you should be giving it. If there be no questions for me otherwise, I will see you Wednesday and Thursday. Please be prepared for the assessment module. We will take the module at the end of class on Wednesday and Thursday after we have reviewed assessment and, more importantly, had a couple of you go through an assessment attempt and give it a visual motor memory to go along with your didactic studying. I remind you again, this module is all about chronological order. It's all about knowing the sheet. Specifically speaking, the medical assessment sheet. Do you know how it flows? Good night, everybody.
Thank you, Justin. Good night.
Good night.